Hello, my name is Valeria Villaro and I'm going to tell to you about supracondylar fractures. Definition: they are the most frequent elbow fractures. Its origin sits on the tiniest portion of the humeral above the condyles and its direction is almost transverse. Now we will see a video about the supracondylar fracture.
Hi, welcome to another Radiology Channel video on the Pediatric Elbow Radiograph. I'm Dr. Jeremy Jones from radiopedia.org and today we're going to be looking at supracondylar fractures. Take a look at these three radiographs and see if you can identify those that have a supracondylar fracture. If you're not already viewing this in high definition, I suggest you do so. You can always pause the video if you need more time. The elbow joint is made up of the humerus, the ulna and the radius. The radial head sits in the radial notch of the ulna and is surrounded by the annular ligaments. It sits adjacent to the capitellum, which is central in the elbow. When the elbow is extended, the olecranon sits within the olecranon fossa. This is the narrowest point of the distal humerus and therefore the weakest point of the pediatric elbow. If we apply force to the capitellum, the supracondylar portion of the distal humerus is the weakest area and therefore the area most likely to fracture. As such, supracondylar fractures are the commonest of the pediatric elbow fractures. They typically occur following a fall onto a hyperextended elbow. As with any fracture, complications include damage to local vessels such as the brachial artery and damage to local nerves such as the ulnar nerve, which can be damaged in severe displacement. A line drawn down the anterior surface of the humerus should intersect the middle third of the capitellum. Since the capitellum is displaced posteriorly in the vast majority of supracondylar fractures, this is an extremely helpful tool for demonstrating correct alignment at the elbow joint. Let's look back at our cases. In case A, if we draw a line down the anterior surface of the humerus, and then draw in the expected location of the capitellum, we can see that a force applied down the radius has displaced the capitellum posteriorly. In addition, there is an anterior fat pad indicative of an elbow effusion. There is also irregularity of the dorsal cortex that represents the fracture. If we move on to case B, we can draw in our anterior humeral line and the expected location of the capitellum. There is no capitellar displacement. However, there is a large anterior fat pad suggesting an elbow effusion, which has been caused by this longitudinal fracture through the radial neck. Let's move on to case C. Again, we can draw in the anterior humeral line and we can draw in the expected location of the capitellum. Again, force down the radius has caused posterior displacement of the capitellum. On this occasion, there's no evidence of an elbow effusion, but if you look carefully in the olecranon fossa, there is irregularity of the cortex caused by the supracondylar fracture. So we've seen two cases of supracondylar fractures, learned that they are the commonest pediatric elbow fracture, and subtle and easy to miss in certain circumstances. In these subtle examples, the anterior humeral line is key. It should always intersect the middle third of the capitellum, and where it doesn't, we should look for associated elbow effusions or minor cortical irregularities that herald the supracondylar fracture. Why not check out some of the other videos on Radiology Channel, including the other pediatric elbow.
Care of nurse. Supracondylar fractures of the humerus in children represent a great challenge for the orthopedic, as it is usually accompanied by important complications such as vascular and nerve injuries, compartment syndrome. The most widely used method was closed reduction and immobilization with plaster. You should not use the affected limb to perform exercise and work that requires significant force. Rehabilitation. The best rehabilitation is to try to use the affected limb normally in its habitual needs, cleanings, food, etc., except for force work. Prolonged bleeding is not recommended. It is necessary to maintain a good level of personal hygiene. You must not forget to comply with the prescribed medication guideline.
The arm is placed up on towels and a target is drawn out over the capitellum. Once fluoroscopy has been used to mark out the trajectory of the pins, they are placed through the skin, aiming to get maximum divergence at the fracture site. The assistant will hold the K-wire and then the surgeon will bring in the wire driver. The humerus is usually on an incline due to the patels underneath the humerus, and this needs to be considered when placing the pin trajectory. The pins are passed until such time as they have bicortical purchase. Sometimes they will pass across the olecranon fossa and encounter 4 cortices. A second pin is then also placed, and again fluoroscopic confirmation is performed in the anterior-posterior as well as the lateral position. Once 2 pins have been placed, stability can be checked. Once the final position of the pins in the lateral projection has been checked on fluoroscopy, dynamic screening can also occur. In order for this to occur, the elbow is brought out into extension, and again a lateral picture is taken. There should be no fracture site motion. Next, the surgeon can grasp the upper humerus as well as the forearm, and under live fluoroscopy assess for fracture stability. If the fracture site is seen to move, a third pin may be required. The vascularity of the limb should be checked at the conclusion of the procedure to ensure that it is perfectly pink and that there is a strong radial pulse present.
Closure reduction benefits. Help the bone heal quickly and be strong when it heals. Decrease pain. Improve the chance that your limb will look normally and that you can use it normally when it heals. Lower the risk of a bone infection. Remove tension on the skin and decrease swelling. Cons. Depending on the severity of the fracture and other factors, you may not have full range of motion after recovering. Most fractures heal well in 6 to 8 weeks. If the fingers are blue, pale, or cold. If numbness, needle-like pricks and tingling appear on the operated arm. If you have a fever temperature greater than 38 C. If you have increasing and constant pain that does not improve even when you take the prescribed pain relievers.
This is an audio-visual representation of a study published in the Journal of Bone and Joint Surgery in 2019. The most common elbow fracture seen in children in the supracondylar region of the humerus, which is thin, weak, and vulnerable to such injuries. The majority of these result from a fall onto an outstretched hand. Most of what is known about these fractures comes from data collected from older children and teens. A team of researchers performed a study in order to learn more about the characteristics and treatment of supracondylar humeral fractures in children. They retrospectively reviewed the records of 103 children between the ages of 9 and 23 months and reviewed the type of fracture, mechanism of injury, rate of malunion, and other factors. They found that the average age at the time of fracture was 18 months, and 63% of the children had a type 3 displaced fracture. 73% of the fractures were the result of a fall from household heights. They also found that the ratio of females to males was 2-to-1, which differed from the data collected from older children where fractures were more common in males. On examining the in-cast x-rays, the team found that many casts were poor fitting and malunions were significantly associated with a poor fitting cast. When lateral column-only fixation was used, the malunion rate was an alarming 36%, but when bicolumnar fixation was used, the malunion rate dropped to 11%. The team also found that 5% of cases were suggestive of non-accidental trauma, consistent with child abuse. Treating supracondylar humeral fractures in infantile patients is challenging. Casts must be form-fitting, and surgeons should be aware of the high rate of malunion associated with lateral column-only fixation.
Conclusion. Supracondylar fractures are more common in children between 6 and 8 years old. They are dangerous because they can cause nerve injuries and in circulation. This can be treated with clot reduction and immobilization through plaster. Nursing care includes infection care after the surgical procedure.